insieme a prendere la luce tutta la notte finché il giorno non verrà. Saremo uniti e come il sonno chiama il sogno, fuori dal tempo e dalla realtà. Un solo grido, l'uomo solo quello, oltre l'orgoglio c'è ancora libertà. Quando la luce avrà capito, più vicino scenderà. Tu chiamami fratello, fallo quando vuoi. Chiamami fratello, fallo quando vuoi. Ormai l'alba abbiamo fatto molta strada, ancora sono con te. Non ci è servito nasconderci dal mondo, lontano dai tuoi perché. Se guardi in alto c'è ancora quella luce, siamo vicini oramai. Dalle colore, dalle forme, dalle voci, dalla forza che hai. Quando la luce avrà capito, non più vicino scenderà. Tu chiamami fratello, fallo quando vuoi. Chiamami fratello, fallo quando vuoi.
Three, two, one, let's go.
Fratelli,
Amici, ragazzi.
Ah, but
Are
here
you?
you are.
Yes, I arrived in time, you see?
amazing.
You are always great. Jeppy
Yeah.
the Great.
Look, what did I see today? Let me show you one picture.
We all wear today black t-shirts.
What is
Can
that?
you can you
What's
see
that?
Oh,
No.
the airplane exhibition.
the airplane exhibition? Yeah.
Nice,
Specie
nice.
tricolore. Nice, eh?
Amazing.
Yeah.
Do you take nice pictures?
Yes, I think so. I have to check. Allora, ragazzi, how are you? I missed you tremendously.
So good.
Turchia, Marocco, Austria, Uzbekistan, Bulgaria, Canada, Hungary, Bulgaria, Macedonia,
We're all black
Kosovo.
today.
Eh?
We are
What's
all
that?
black today.
France, Ukraine, Venezuela, Trento, Romania, Argentina, Brazil, Azerbaijan, Athens, and UK.
Fantastico.
Hello to all of you, all over the world. Can dermoscopy fail is the question of the week. Can dermoscopy fail? Yes, no, sometimes.
Yeah. Sometimes it's definitely the most voted one, eh? You see? No is
Why
no,
100% no?
no for 5 people. Yeah. Can the Moscow be failed? No. Yeah.
No, never.
Not it. Never.
It's
Ah,
our mistake, not the
fantastic.
dermoscopy's one.
Fantastico.
Hello from Ecuador. Ecuador.
Ecuador.
Nigeria.
Yes. Beirut. Wales.
Wow, next week we do them up?
Yeah, for
We
sure.
have to. Yeah. So, ragazzi, what is the topic for today? When the Moscopy fails.
Yeah, can it happen?
Yeah, yes,
Sometimes.
sometimes. Yeah,
Yeah.
can happen. So what did you prepare, guys?
Let's have Nisa start because the
Yeah,
other.
I have cases.
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 Yeah.
Wonderful.
I prepared only 4 cases for you. Yeah, because otherwise it's too.
No, because you cannot find in your entire database more than 4 examples where the dermoscopy failed. That's why.
Exactly. Yeah, you're right. Yeah. I was struggling to find some.
Yeah.
Yeah.
So you start first, JP.
No. Vai, Nisa, vai. Go. Go.
Okay.
This will be the shortest episode that we will have when the dermoscopy fails.
Mm. Yes.
Yes. And this is a lesion on the breast of a 74-year-old female. So what's your clinical diagnosis here?
Step care.
Seborrheic keratosis.
Seborrheic keratosis. Let's have a look at dermatoscopy. Is it a
Oh.
seborrheic keratosis?
Well, it could be, but now the situation is a little bit more troublesome.
More like Bowens.
Yeah.
Okay. Now this was
Seborrheic keratosis.
polarized.
Yeah.
Non-polarized. Is this a seborrheic keratosis?
Eh,
Let's go back. Polarized,
Yeah.
non-polarized.
Something is wrong in the center, of course.
Yeah.
but there are also
Maybe there are
milia.
some here media-like cysts
Milia.
which are visible in the polarized mode, but we are not so sure about it, right? Because we
Yeah.
have segmental radial lines at 9 o'clock. And this is sub-UV mode.
Mm-hmm.
And here you can see white plots again.
Mhm.
So this is, it could be a seborrheic keratosis, but
Yeah.
we are not so sure.
Mhm.
Yeah.
And here are differential diagnoses.
Uh-huh.
Which one?
I think Bowens.
So, but then if this is Bowens, dermoscopy didn't fail. Dermoscopy moved on the right side. If this is a simple seborrheic keratosis, then dermoscopy fails.
Yeah.
Comparing
Now
to
here are
clinical.
some comparisons, polarized, non-polarized, and this is the base of the lesion. And let's have a look at the vessels. We have looped vessels at the periphery. Can you see it?
Yeah, I still go with seborrheic keratosis, I have to say.
Yeah,
Yeah.
me too.
Actually, I was also thinking about this is a seborrheic keratosis, but wasn't so sure about it because it wasn't a very typical one. But just with sub-UV mode, when I see these looped vessels at the periphery of the lesion, seborrheic keratosis was most likely diagnosis for me. It was. So here, dermoscopy fails or not.
Yeah, definitely, because the clinical diagnosis was straightforward.
Yeah, clinical
Dermoscopy
diagnosis was straight. Dermatoscopy was a bit challenging, right?
Dermoscopy complicated the situation.
Yeah,
I agree.
exactly. And here are those looped vessels in the close-up, you can see. And now we are going something more challenging. 40-year-old female, and the lesion is there since she was 13 years old. So it's a long-standing lesion.
Mm.
And here's the dermatoscopy.
Mm. Mm.
What do you think it is?
Aglissimo.
Yes.
Very ugly dermal nevus. Very
Does-
ugly dermal nevus.
Does the word aglissimo exist in Italian, Jeremy?
No,
This is
bruttissimo.
non-polarized, polarized. So I was thinking about there is a melanoma arising on a dermal nevus or a trichoblastoma because it was there since she was a child, but pathology was none of them. This
is an answer given in the chat. Pilomatricoma is an answer given in the chat. Atypical spitz tumor, another answer. Excision, of course.
Yeah.
And those are the options. So which one you vote?
BCC.
BCC, Emilios?
let me vote. Well, the reasonable is melanoma rising or nevus, but probably that's not the answer.
Yeah.
So then, yeah, trichoblastoma.
JP,
I go for nodular BCC.
BCC
no,
was
there-
taken already.
it's none of them.
Poroma then.
It's poroma.
Okay.
So can we say dermoscopy fails here?
Yes.
I think yes.
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 Another one.
But
Another one.
in any case of poroma, dermoscopy fails.
Okay, let's have a look at this one. The pink one on the back, this one. This is polarized. Just look at the dermatoscopy, and we have some calcifications and branched and serpentine vessels. This is
Go back,
non-polarized.
go
and
back
we
to the
still
clinical.
all those
Go back to the clinical for a moment. Okay.
Okay.
a lot of May globules, but large May globules and serpentine and branched vessels. This is non-polarized, and we still see all these calcifications. And this is UV dermatoscopy. Again, we have all those calcifications and vessels. And this is sub-UV mode. Vessel pattern is much more beautiful here. And here you can still see the calcifications. And what's your diagnosis here?
Well, you want to convince us that this is not a
It's not a
BCC.
BCC.
Yeah.
I
So-
feel like a sub K for some reason.
SEPK?
Yeah.
Are those vessels common in SEPK?
No, but a traumatized one can be whatever.
But we have these calcifications in UV mode and sub-UV mode. If these are milial-like cysts, we shouldn't see all those calcifications in these modes, right?
Yeah.
Well, it's a gut feeling. What can I do?
Adnexals, of course, might be.
So, Emilios, what do you say?
Yeah, I say also BCC, of course.
JP,
But adnexals are also in the game again.
So, I mean, we are discussing this case because this is not a BCC. Otherwise, it's very easy. So I cannot go for
actually,
BCC.
I was thinking about BCC or trichoblastoma here,
Yeah.
and histopathology was a surprise.
Poroma.
Another poroma.
Okay.
Yeah.
Okay.
Yeah.
Lovely.
Very funny.
Yeah, very funny. And this is my last case. This is on the chest of a male, and he has a skin type of 5.
Dermal nevus. Oh my God.
Here's a
Ooh.
dermatoscopy.
Oh my God.
It was wobbling.
Yeah.
And this is the inferior part of the tumor. And here's the close-up.
So again, this is just a simple dermal nevus, but dermoscopically is so ugly.
So ugly. This is not a very typical dermal nevus, right?
No, of course not.
So what do you think? Konstantinos, tell me, please.
Histopathology will determine. Take it out. I have no idea. But I will take it out not
Emilios
because I'm worried.
Also, heavily pigmented BCC is an option. We cannot exclude.
and JP.
BCC.
I still go for dermal nevus.
Dermal nevus.
Okay. This is polarized and non-polarized. Again, with different dermatoscopes and UV modes and sub-UV modes. Nothing changed. I think it's still very challenging. So diagnosis was here. Poroma.
Poroma.
So my message is,
Which is the
dermoscopy
diagnosis?
always fails
Poroma.
in poroma.
So this is a poroma again.
This is the message of tonight.
This is a poroma again. Wonderful.
Yeah,
Nice.
yeah. Poroma is always a challenge.
Do you remember, Jeff? It was 10 years ago, or more than 10 years ago. I was in Italy when we had our first cases of poroma excised. then at the very beginning, it was, and then we published that paper. You remember that paper with 10 different poroma patterns, each one mimicking a different diagnosis.
Yeah.
It's
Yeah.
yeah, it's fascinating.
Okay, so
And we
the
just
message
published
is-
a paper on poromas in Skin of Color, and it's published in DPC this month.
Yeah.
Really, they're all very challenging,
So the message
very
is
difficult to diagnose.
dermoscopy does not help when it's the case of a poroma.
Yeah,
With some rare
exactly.
exceptions, of course, which is not dermoscopy. Mainly, it's when it's located on the sole. Then you, because of the location, you have a clue.
Yeah.
Then probably you think about it. Yeah, but
Yeah.
usually dermoscopy is not sufficient.
Sebastiano today looks very similar to me, right?
Yeah, really, pretty much.
He's also
Today
black.
I am you. Today I am you with my name.
Yes. Va bene, vai Costantino.
Constantino.
Yeah.
Okay, so wait, just 1 second. So when dermoscopy fails, and we could put a question mark there, never, ever, ever. Well, sometimes. I tried to accumulate the experience from, well, if I can remember, although I'm getting very, very old right now, from when I was first learning dermoscopy. And furthermore, the feedback that I get from my residents. So what we need to keep in mind is dermoscopy does fail when we're at the beginning of its use. So dermoscopy has a learning curve, which is approximately 6 months to 1 year, that you need to familiarize yourself. Because at the beginning, we learn about all these melanoma-specific criterion, a typical network, streaks, all those things. And when you first encounter them in clinical practice, people are quite scared because you can see them in a lot of benign nevi. Experience is what makes you to, leave the fuss out. But as we begin, so for example, here on these patients with a typical mole syndrome, this is not a great typical network. And I'm taking these examples from everyday practice with my residents, asking me, but why don't you take this out? This is an atypical network. It stands out, but it doesn't. So this is a network. Is it great? No, but it's not that bad. And I think this is something that we need to keep in mind, that at the beginning of our training, we will see many things that will scare us. But as we move forward, we'll learn how to let them go. Another case where dermoscopy is confusing is regression. I think that you all have encountered it with your residents. So in this case, a patient with multiple atypical nevi, and my residents always ask me, so isn't this regression? There's nothing here. No, it's not regression, because if you pull the pressure out, you see that it's a homogeneous pattern. And this is the dermal part of compound nevus. And this is something that's very confounding for many people while they begin learning dermoscopy. And I think this is something that we need to focus our efforts on. So I think that one point where dermoscopy fails is the first 1 year of usage, where you see things and you just see melanoma-specific features. This is something.
Costa, may I interrupt you? Dalia in the chat says Jesus Christ sign. Does any of you have any idea what this refers to?
What's the Jesus Christ sign?
The only thing I can imagine is that when you have a lesion, you excise it, you get the histo report back, and then you say Jesus Christ.
No, the thorn. I suppose she's referring
the
to
crown. Oh, gotcha. And
Really?
you know that the first thumb syndrome, the first FAM syndrome was described. So the initial atypical mole was described as this fried egg pattern. You know it back in 1992 by Alan Halpern. So these were the ones that were the designatory of an atypical mole syndrome.
Yeah.
Of course, as we moved on, we learned more and more. But this fried egg sign was the atypical mole syndrome sign. Another case where dermoscopy fails or is difficult is small lesions, because in very small lesions, everything is so compact and it's equally difficult both for dermoscopists and histopathologists. So this one is comparatively clear cut. Leg of a female, multiple atypical blotches. So this is a melanoma. But very commonly, my residents will come to me in a 2 mm lesion. So why is this network not atypical? So why is this not a melanoma? Because it's too small to know. Like,
Yeah.
is this going to grow? I have no idea. Most likely not. It looks to have taken its final form. It's just a small nevus. It's very difficult to separate features in tiny lesions. And this is a case where dermoscopy can be cumbersome.
Yeah, but in the previous example you showed, it's a classic example when dermoscopy, it's a triumph of dermoscopy because it's so small, but dermatoscopically it's so clear cut.
It really is. But there are several other small lesions like
Yeah, that you cannot say. Yeah.
that you cannot say. It's very hard to tell.
Yeah.
Another case where it's not dermoscopy that fails, but our understanding of biology, and dermoscopy has exacerbated that, is peripheral globules. So this is a 44 or 45-year-old female with peripheral globules. You know that maybe 5 or 10 years ago, this was a sign that this needs to come out, right? We saw these globules. This is a sign that it needs to come out. Again, a lesion of 3 mm, right? But again, this was something that was clarified with later research. And always we need to, now we know that nevi can grow even later in life. And furthermore, we know how to put it into context. So this lesion is very different from this patient with a history of melanoma and this tiered globule pattern.
Baba, kendimi bildim bileli seni.
Nisa,
What's happening?
what was that? So 55-year-old male with a history of melanoma, small lesion again, but these tiered globules showing like a spizoid within quotations morphology.
Exactly.
Yes. So spizoid lesion in a 55-year-old patient, it's totally different than this scenario, right? With a single line of peripheral globules. And of course, the spizoid-looking lesions are always tricky ones. This was a 42-year-old male. This came back as a spitz nevus. Do we believe it? Yes, but it's always a tricky part of dermoscopy on how to interpret things given the context of the patient. Another thing that has been a very confusing factor up till now were blue nevi. Blue nevi, we've become better and better at identifying them, and dermoscopy has helped a lot. I want to, because this is still a very common occurrence, and I want to bring your attention to this wonderful paper from 2014, acquired blue nevi in older individuals, where they retrospectively examined acquired blue nevi in elderly individuals where the mean age of biopsied for melanoma, where the mean age of diagnosis was 62.8 and the mean reported age of presentation was something like 10 months. Everything they reviewed 200 and approximately 200 nevi, 204 blue nevi consecutively biopsied, and they were all blue nevi. So this is a really nice paper that I think has changed our approach to the patients and how we interpret dermoscopy. And another another case where dermoscopy can be a bit confusing is highly keratotic lesions. So can you tell for certainty if this squamous cell carcinoma or an irritated ZK?
No, tough.
Yeah.
So exactly, this is another case where dermoscopy can be more confusing than helping. This lesion will be biopsied. Of course, another case is heavily pigmented lesions where putting the diagnosis is difficult. Of course, this is not a big problem because this lesion will be biopsied, of course. But heavily pigmented lesions are always a difficult factor to weigh in. And I think another very important, there are two important final points to make. This is a young male, 32 years old. He has had this allegedly since he has had a vaccination. Looks like ADF, right? Unfortunately, the image is not very, very good. Do you see this vessel? This was a beautiful arborizing vessel crossing the center. So although you're sure that this is a DF, when you see a feature that is not supposed to be in a clinical context that you have already made the diagnosis, and you see some features that are out of place, this can be a confounding factor and lead to more biopsies. Of course, this is not very common. In the vast majority, this will not happen, but it can happen, and this is one of them. And the final point that I want to make, I always put this in my presentations, never, never, never rely on dermoscopy alone for nodular lesions, because this is the case of a 40-year-old male with this yellow lesion, yellow-purple, that was the yellow melanoma that I didn't put in the high priority because I thought it was an adnexal tumor, and it was excised 1.5 months afterwards. Did it change much? No, but still, I shouldn't have resided so much in dermoscopy in nodular lesions that I have no idea what they are.
Wonderful.
Very good.
What was the diagnosis of this big nodule on the back of this young gentleman?
Melanoma.
Okay.
The alternative would be heavily pigmented BCC, but
Yeah, it was 11.5 Breslow.
Oh,
Yeah.
terrible.
Well, so what you wanted to point out is the fact that dermoscopy does not can fail at the very beginning, and it's definitely something we have to remember until we are improving our learning curve. We don't have to put too much, let's say, trust in what we see dermoscopically, and this is a very good point. And the second point is that from what you showed is the fact that we always need to consider everything together.
Correct.
Dermoscopy alone is nothing. We need to consider what we see dermoscopically in the context of the clinical scenario of the patient. And this is extremely important. By the way, I didn't know about this blue Nivus paper. It's very nice. Yeah.
It's one of my favorite ones.
Yeah.
it's just Jeff, because you start to forget. We spoke about it many times
About this paper, really?
because this was supporting very much our theory that
But this is a good stuff of elderly, that you have that you forget, and it's always brand new,
rediscover things, and you're happy, like watching a movie for the third time, but you get the same pleasure as the first one. I agree.
And videos, and it's very common in bald male scalp.
Yes, of course. Yeah.
No, but if you look at the stats, so sorry, let me share for one moment, because this is honestly one of my favorite papers in the essence that it's one of the papers that changed practice. So location, scalp 33, forehead, temple 16, arm 58. Like we see it on our everyday practice, and still we get a lot of colleagues saying that this is new on a 70-year-old. It's okay. It's a blue nevus. What can we do?
Yes, but come on, this is our fault because for decades we have been teaching and writing in the books and everywhere, and it's out there everywhere that the diagnosis of a blue nevus should always be confirmed by the history of a stable lesion and so on. So it's not easy to change.
Yeah.
Yeah.
Yeah, it's gonna change, but it's gonna
Yeah.
take a decade maybe.
Wonderful, wonderful. Couple of questions. Cases where the dermoscopy clues for poroma. No, 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 no. Poroma always fails when we are facing with the poroma.
Well, we have the blooming
Almost.
flower.
Yeah, the bosom flower vessels in very typical cases, but these are very few.
Yeah.
And do you monitor growing nevi? No, I don't monitor growing nevi in young individuals. I don't care at all.
But now they're gonna ask you until which age?
Until 75.
It's a joke. It's a joke, but true. We have this, a slide, a very famous slide that we use often when we speak about growing lesions. And there, in that slide, in the original version, it was written that until 45, no worries, from 45 to 65, I don't remember, monitoring, then after 65, excise. And then we used the same slide in subsequent versions, precisely the same slide, just changing the, the number.
The
So
number.
in the current version, the slide has the number 65. I mean, maybe in the future, it's going to have the number 75.
But just one point on this, I think I've discussed this again. In people with atypical mole syndrome or with multiple moles, because they have such melanocytic activity, you can see new moles and growing moles up to the age of 80 or 90. It doesn't change anything. They have such melanocytic activity that they produce new moles. It's the way it is. So different context.
Yeah. No, this is also based on the idea. So I was very prone from the very beginning to believe that it's wrong what we say about peripheral globules. It's also based on the notion that if you have a pattern of peripheral globules, this means already an organized pattern. So there is already an organization in the way that these globules are distributed, and this is a good sign. This is a good sign. In a melanoma, you don't expect an organization of the pattern.
Yeah.
So,
yeah. Bene. Who goes next? Who goes next?
Maybe Sebastiano, a video or no? It's
Sebastiano, you like to propose a video? Why not?
no,
Why not?
doesn't want.
No.
Who doesn't want?
No. Okay.
Good. JB, you wanna go?
I go? Va bene.
Wait.
Wow. Beautiful.
Have you been to the Avent Springs?
Yes. Yes.
How was it?
Hey, it's amazing. It's amazing facility. Very nice. Bene, 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 bene. Just 4 cases for you guys. Help me, help me.
25 cases, I see.
Sì, 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 sì. Ok, allora, this is a 60 something year old person, clinical diagnosis,
Seborrheic keratosis.
seborrheic keratosis.
LPLK.
Easy. In my view, this is an easy seborrheic keratosis. Just let's give a look dermoscopically.
Much less easy
Less
seborrheic.
easy.
Now it's more complicated, right? Yeah. And now I ask myself, why should should I look dermoscopically? An easy
Okay.
seborrheic keratosis. And of course, the lesion was excised, and indeed, it was a seborrheic keratosis.
Ah,
Yeah. Yeah. You see,
an
this
ugly one.
where the dermoscopy fails. In my view, it's not very common that dermoscopy is confounding in comparison to the clinical, but sometimes it happens. By the way, it was diagnosed as a melanoacanthoma, which is a very sophisticated way to describe heavily pigmented seborrheic keratosis histopathologically. Now, second case, you see the flank of a 50, 55-year-old lady, maybe something more. I don't remember the precise age. Clinical?
Again, SebCare could be,
Okay.
or BCC.
But this is nice because, in my estimation, this was quite ugly clinically. But anyway, let's have a look demographically.
Subcare.
Yeah.
LPLK.
Yeah, seborrheic keratosis with this kind of big,
Migration.
large grayish globules. There is some on the left side, I see this kind of papillomatous brown structures reminding me to a dermal nevus. So in my view, this is very confounding because whatever I think it's just a benign stuff. Either it's a irritated dermal nevus or it's a lichen planus-like keratosis. Fortunately, the lesion was excised anyhow, and this was melanoma 0.7.
Wow.
Everything.
wow.
Unbelievable. Really unbelievable.
Yeah.
Really looks like a seborrheic keratosis going regression.
Exactly. Really disappointing. Really disappointing. So, in retrospect, clinically, in my view, this was quite outstanding lesion. Ugly duckling, yeah. And dermoscopically, by the way, it was more on the benign side. So it happens from time to time.
Really very surprising diagnosis.
Exactly. Of course,
Probably I wouldn't excise this. Just according to clinical appearance, I would excise, but dermatoscopically, it really looks like seborrheic keratosis.
Yeah, it's very, very difficult that we are going to miss this one because we anyhow we are going to excise it. Because we have anyhow for a lichen planus-like keratosis like this one. I mean, a lesion looking like lichen planus-like keratosis. In a case like this, you prefer to excise it. Anyway, this is disappointing.
Debbie, I think I would have missed this one.
Yeah.
Not clinically, but
me
once
too.
I put my dermoscope, I'll be LPLK.
Yeah.
But it's not. It's probably easier. I mean, as looking at the photograph, and you have to.
Maybe, but
yeah. One more. I like this one. Yeah, I mean the clinical is very. I mean, not very easy to assess. Dermoscopically, we have a bluish.
Poroma.
Brava, brava, for Roma. You
The
see,
skin of color patients.
you see that also in my collection of cases, I was putting a poroma because poroma is almost undiagnosable. Yeah. And last case is this one. This is a very clean back. You see there is almost nothing. There is just one lesion here. Clinically,
BCC.
BCC, a strange seborrheic keratosis as well. Anyway, dermoscopically, more on the side. I mean, this is the kind of this finger pattern on
Lesion.
top right. Collision among what?
Seborrheic keratosis and BCC.
Seborrheic keratosis and BCC. Brava, Nisa. This was exactly the same thought as the clinician who assessed the lesion face to face. Unfortunately, of course, when you diagnose a lesion like a very probable collision between BCC and seborrheic keratosis is not growing to priority A, priority B, so it's going it's going out in 2-3 months.
Yeah.
So this was going out in 3 months, and this was a melanoma 1.5.
Yeah.
And this is very, very disappointing. Very disappointing.
And no seborrheic keratosis collision,
No.
JP, all melanoma?
All melanoma.
Mm-hmm.
All melanoma. There was no seborrheic keratosis here, unfortunately, but everything was melanoma. Yeah. So, of course,
Great cases.
of course. I mean, these are the cases where we have to think about, from this case, in my view, we have to learn something like, if I'm sure, let's say, my diagnosis is very confident that this is a BCC, then you can put this lesion in 3 months for excision. But if you are confronting with a peculiar lesion, a collision lesion, whatever, I mean, certainly nobody of us could put $1 million on the diagnosis of BCC.
Sure.
And it's better to do it in priority, in urgent priority, excise it as soon as possible. Yeah.
Great presentation.
Okay, Emilio, show us your cases.
Yeah. I'm just trying to pick up the very famous collision that you know. Anyhow, yes, sure. Let's go.
A famous collision.
A very famous collision. You will see. You will understand.
Okay.
Okay. Let's start with the first one. I think I've shown at some time this case again, but there is a nice story behind. So that was a lady with some lesions. There is one on the thigh that looks like a nevus, but it's a bit interesting. So we check with dermoscopy, and that was at the moment that I had a lesson with students. And then at the moment, or residents, I don't remember, at the moment I put my dermatoscope on, I say, whoa, this was not expected, guys. You see here the blue clots. And then the blue clots is a very strong sign for BCC. So you should look with your dermatoscope everything, because you could have missed it, thinking that it's a nevus, while when you see the blue clots, you know that there is no nevus with blue clots. I also explained the theory why there is no nevus with blue clots.
You were very enthusiastic, very intuitive.
The residents were very wow, yeah. But then when the history report came back, it was such a shame.
With a nevus?
Nevus.
In Skin of Color, we have a lot of blue clothes.
Yeah, but come on. I mean, come on. That was a nevus. So here, dermoscopy was the reason for the wrong assessment. Of course, no harm done, but it happens sometimes. Of course, we know that blue clots is a strong clue for BCC, and this explains the problem. Similar problem, again, I remember the case. I've shown it many times. I remember also the story, a lesion looking ugly clinically. I mean, looking suspicious for melanoma.
Yes.
Not ugly, generally speaking, ugly for melanoma, suspicious for melanoma. And then with dermoscopy, you see
Bowens.
exactly Bowens. So you see these brown globules in a linear fashion, which make you think that it could be Bowens. And this is very, very worrisome, because if you think it's a Bowens, there is a chance that you might decide to treat it with cryo, which would be a disaster in this case, because it's a melanoma, it's not Bowens. Yeah?
Ah,
So again here,
great case.
without dermoscopy, we were, all of us, I think, correct. With dermoscopy, some, especially the experienced ones, would see a clue that is missing. Of course, overall, there are additional things that can make you question the diagnosis of Bowens, but there is definitely something potentially misleading in the dermatoscopic image, which are the brown clots, the brown dots,
Maybe
globules.
white structureless is a clue for melanoma here.
And that's the classic Bowen with the brown dots in line, and there is an obvious overlap here, as you can see. Another case that I have shown, I think, again in the happy hour, I will never forget it, and I don't have anything didactic to say or to extract.
Don't tell me that this is not a BCC.
It's not a BCC.
Melanoma.
This is a melanoma. And based on clinical, I think that we could say melanoma or BCC. Yeah? But definitely,
Infiltrative.
clinically, you cannot say that this is much more.
So again, you know, and that's the rule I try to apply nowadays, you know. Of course, also in this particular case, I cannot be 100% sure that this is a BCC. So probably my wise decision should be to excise it as soon as possible.
Exactly. That's the point. That's the point, that even when you say, okay, it should be a BCC, but should be is different from it is a BCC for sure. When it should be a BCC, then we try to excise it.
Yeah, it should be high risk BCC.
As soon as possible. Very good. Another case, a nodule on the face. Of course.
Purpura dermatosis.
Yes. Okay. But now we know. But
now we start to understand how it looks like.
Before this, look at dermoscopy.
It looks like a low differentiation squamous cell carcinoma.
Yeah.
Poorly differentiated squamous cell carcinoma should be the
carcinoma.
Based on the quantity of vessels that we see, the type of
very atypical Merkel, maybe.
Yeah. Okay, but now we know, so we can clinically recognize this entity. By the way, resolved in 1 week with no problem. And look this other image and see how repetitive this pattern is. So again, same stuff. Many linear vessels in an orange background. So again, erosive pustular dermatosis. Another case on the eyelid, and that's here there is a didactic message in my view. A case that looks dermatoscopically like a basal cell carcinoma.
Yes.
Yeah.
But if the patient is very young, it could be still a dermal nevus.
A dermal nevus, exactly, and it's not only
a great mimicker. Yeah.
It's not only this case. There is a study that suggests that dermal nevi located on the eyelid often display vessels that look quite a lot like the vessels of BCC. That was a study by the group of Ash. So we should keep it in mind on the eyelid that there is this possibility, and this could be a trap. Often, I would say, with nevi located in this peculiar location. Another completely different scenario. A plaque on the chest.
Fibrosarcoma.
Dermatoscopic. Clinically, you said fibrosarcoma.
Sì.
Morphiaform BC.
Morphiaform BC.
Morphe, BCC.
You say when you see dermoscopy, but it's misleading. The clinical was correct. It's a fibrosarcoma.
Morphea.
It's a dermatofibrosarcoma protuberance that dermatoscopically looks a lot like morphiaform BCC, and this happens in this atrophic variant of DFSP. There is this atrophic variant of DFSP, and here the overlap with morphiaform BCC is very important. By the way, this is this is the study. That's a morphiaform BCC. This is the dermoscopy of the morphiaform BCC, and look how much similar they are one to the other. Very much. Okay, that's another potential overlap. I think I have two more cases. That's inflammatory category. Clinically, I don't know what would you think about. Maybe
Granuloma anulare.
Lichenization.
Lichenization, so something
Neurodermatitis.
chronic. Yes, chronic
Lichen simplex chronicus.
Lichen simplex chronicus, yeah. I don't know if you also think about lichen, what's the name? Amyloidosis.
Amyloidosis.
Yeah.
Okay.
Macular.
Yeah. Okay. Okay. And then in dermoscopy, you have this. You have rosettes. You have
White lines.
tiny white lines. A few.
Hypertrophic lichen.
Dotted vessels. Yeah.
This is not a psoriasis.
I
No.
have no idea.
Hypertrophic lichen planus or something like.
Yeah, something towards lichen, maybe because of the white lines that we see.
Because of those white lines, yeah.
Yeah, we could think something towards lichen, which is completely wrong, misleading again. So it's a Kaposi, guys, and you know we expect to see the, the rainbow, but the rainbow is present in nodular Kaposi.
Nodular.
Not
Nodular. Not plaque.
In plaques of Kaposi, as was shown by this study that you did, Nisa, in flat lesions, often, very often, we see white lines, white clots, and rosettes also. And we don't see so often the polychromatic pattern, the rainbow pattern that we see in nodular lesions. This is also something that could be misleading. Okay, very quickly, another case of that dermoscopy is misleading. Clinically, what do you think it is? Hypertrophic AK or seborrheic keratosis or squamous cell?
Yeah.
Oh.
Okay, with dermoscopy, you say that this is a
Squamous cell.
squamous cell,
SCC?
SCC, and it's wrong.
What is it?
What's that?
Inherited seborrheic keratosis. Come on. Okay.
Oh, really?
Of course, here dermoscopy misleads in the way that it makes us much more worried as compared to the clinical. With the clinical, we were more or less relaxed. Then we became very worried because of the dermatoscopic appearance, but this was eventually misleading. This is my
Owen, for sure. Owen, for sure.
For sure. Confirmed with dermoscopy?
No.
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 Not
There were
confirmed.
elongated vessels.
There are blue clots.
Poroma.
Poroma.
It's the poroma.
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 No, come on, it's not a poroma.
It's a poroma.
Poroma.
Come on. Come on, fuck off, poroma. Poroma.
I can get all poroma. I'm an expert of poroma.
These are the methods that we mentioned before. The what's the name? Cauliflower. Like
No,
cherry blossom vessels.
Yeah, cherry blossom.
Cherry blossoms.
And finally, this is the famous collision, but I don't know if I should say.
Yeah. This is my very famous figura di merda.
The definition of the failure of dermoscopy, because the story was that a resident was examining the patient. He thought that everything he had was a seborrheic keratosis, everything benign. So he was about to discharge the patient, saying that everything is benign. And then JP came in the room. He looked with the dermatoscope and he said, "Oh, That's wonderful. Of course, this is a seborrheic keratosis, but in the center, there is also a BCC. So it's a collision between BCC and seborrheic keratosis. And then, of course, again, the residents were super impressed.
Wow, Jeffy, yeah.
And all this stuff, yeah, and so on. And then, the usual stuff. And then the report came back, and this was a poroma. And the patient said, "What is a poroma?" And they said, "Nothing, don't worry." And the patient said, "So the residents were correct."
Was right. I should avoid excising this. Yeah, bene.
Great.
Grande. Va bene. I see an interesting question for you, Emilio. Can you explain briefly why no blue clots in nevi?
Yes, because the nests of dermal nevi are located superficially within the dermis, so immediately below the junction, and that's why the color of the clots is brown. The only nevus that has cells deep in the dermis is blue nevus, but in blue nevus, the cells do not form nests. They are diffusely distributed, therefore we see structureless blue color. Therefore, in theory, there is no nevus with blue clots, not only in theory, but also in practice. But of course, for every
exception.
For every rule.
Emilios, in skin of color, Tyndall effect is very strong. And we have a lot of blue clots in skin of color patients. So it's very normal to me. When you say that this is basal cell carcinoma, I was just thinking about, no, come on, this is a dermal nevus of a skin of color patient.
Yeah, but this is not a skin of color patient, by the way.
Yeah, it's very common.
But this is very funny how different is the setup of our mind based on the prototype of patients we see. I will always remember the first couple of years in which Iris was coming to Italy to work with Neapolitan patients. For her, everything was melanoma, all these very dark lesions and so on, while in Austria, everything is very lightly brown, very fair skin and so on. So when you see a dark lesion in Austria, it's a melanoma, while in Napoli, it's not a melanoma.
Never a melanoma. No, but I think the most difficult population in Italy is the northern Italians, that they have all these regressive nevi and all these pale nevi. It's like, when I see like the data sets with northern Italy, I'm like, I have no idea what's going on.
Yeah. Molto bene. We have another video? By chance? Yes.
Which dermatoscope offers a crystal clear image, no matter if you prefer closer or a greater working distance? The Delta 30, with its real 30mm field of view, offers with the achromatic Heine optical system an extremely sharp image. It has a completely homogeneous illumination with razor-sharp edges, even at the borders and edge-to-edge clarity, without distortions and high color accuracy.
Wonderful.
Excellent.
Fantastico. Guys, did you hear the news that there will be a global, worldwide online protest because Dermoscopy Happy Hour is going to stop in 2 weeks?
There will be a strike worldwide. Strikes worldwide.
Right. Yeah, the dermatologists all over the world will not work for 1 day. Yeah.
Okay. So, and Sebi, you have cases for us?
Yeah, a lot
Ah,
of cases.
wonderful. Show us. But why, Sebi, you have this kind of black
Yes.
boxes?
You see or not?
Yeah, yeah, we see some.
Have it.
But there are
Is it
some
there?
black holes.
Squares.
And also you have the old version of the happy hour. Like only two.
No, because Bruno Brunetti send these
Uh-huh.
games.
Okay, but we don't see it very. I mean, we see just one.
No, Sebi, send it to me so I will present and you'll talk.
Okay,
Ah.
let's show first Penelope.
Yes.
Yeah,
Why
it's
why
okay.
do
Okay.
Constantinos? Okay. Penelope, melanoma thickness was the topic of the previous episode. So the cases are related to this topic. The first one, 91-year-old man, past history of non-melanoma skin cancer, long-standing pigmented patch on the forehead. That's dermoscopy. Okay, I think everything is clear.
In situ.
Can you guess the thickness of this melanoma? In situ. Should
Looks like in situ.
be in situ. We don't see any blotches,
Mhm.
gray circles, zigzag pattern, rhomboid, annular, granular. In situ, lenticular, maligna, everything is visible here, no problems. Constantinos, blue color, 71-year-old, plethora of mold lesion that flashes under the eye of my dermatoscope on the lumbar area. Oh,
Wow.
Okay.
okay. That should be the polarized mode. Yeah. Yes, the thickness of this melanoma.
2.3.
Mhm. Yeah.
1.5.
1.5.
Yeah.
2.1. 2.1.
Yeah. Okay. Okay. Disorganized pattern, of course. Blue blotch, crazy vessels, white shiny lines, milky red areas. 1.5, impressive.
Mhm.
I expected it to be deeper. But
Yeah,
bravo, Debbie.
Yeah.
yeah, me too. But why did you say 1.5 with
Because
this?
of the clinical. The clinical was not very raised. It was middle range.
Hmm.
It's a small lesion.
Yeah. Because dermatoscopically here, there are the features of very thick tumors.
Vessels, blue
Mm.
structureless white lines. I was just thinking about thicker than 2 millimeter.
Me too.
Yeah, right.
Okay.
I was sure that it was over 2.
Paleontologist,
Paleontologist.
39-year-old paleontologist. What is a paleontologist? It's a guy digging
39 or 99? He
Studying
looks very old. Not
the earth,
39.
the prehistorical earth.
his wife, of course, is concerned about this recently appeared pigmented lesion. Yeah, he's not 39,
He's
obviously.
right. He's right.
Yeah. Okay, that's
Ah.
the dermoscopy.
Mhm.
Yeah.
What are you saying? Not in situ,
Not
right?
in situ, but definitely less than 0.8.
Yeah, thin is
0.4.
0.6. 0.5.
Okay.
0.4.
We agree here. Segmental radial lines, of course. White shiny lines and gray, which is the reason why we say it's in situ. This is the reason why we say it's in situ. And in fact, it is as it should be, F0.5 melanoma. The next one for me, classical now, 64, pigmented flat lesion on the thigh with nice prominent skin markings.
In situ.
Yeah, so come on, architectural house, the irregular reticular pattern, gray structures, prominent skin markings, in situ melanoma,
In situ.
or no problems. And the last one for Sebastiano, scalp again. That's dermoscopy, 67-year-old past history of numerous squamous cell carcinoma, non-melanoma skin cancers, a pigmented lesion on the skin extensively affected by actinic keratosis, the skin surround, on his scalp, and that's dermoscopy.
Bowens.
It's not Bowen.
There's regression.
Looks like Bowen, yeah.
Looks like bones, but regressive melanoma.
Yeah.
Maybe
Then.
it's actinic keratosis, pigmented.
Yeah, but I mean, we are speaking about melanoma thickness.
It's a melanoma. I'm helping, so we just
0,
Uh,
0.1.
0.2.
regression.
0.4.
Yeah. White yellow scales, hypopigmented structural background. This
Bones.
Wow, this bound. See, it
This
makes it
Bowen.
right.
okay, so it's not misleading. It's not misleading. It is
Yeah,
very good. Very good.
very good.
Excellent.
Wonderful. Thank you very much, Penelope. And are we ready with?
Yes.
We have the case. Konstantinos has the case.
Okay.
Yes, and Sebi will present.
No, you go.
Okay, so it's not uncommon for
Thank you.
dermatologist to encounter uncooperative patients during his professional career. Female, 79 years old. This patient was examined in 2020 after careful clinical dermoscopic examination. A diagnosis of LM, LMM was suspected, and an incisional biopsy was recommended. Patient declined the suggestion. After 2 years, the patient went to the clinic again. The clinical dermoscopic pictures confirmed the suspicion with greater evidence, but this time the patient agreed to perform an incisional biopsy, which confirmed the diagnosis of LM, lentigo maligno in situ. So 2020, 2022, and here we see the dermoscopic differences.
Mhm.
However, once again, the patient showed us her uncompliant character by refusing surgical intervention.
Very good.
Faced with the refusal of surgical approach, we decided to treat the patient with 5-FU for 2 cycles of 6
2 cycles.
with the excellent results that you can appreciate.
Oh, wonderful.
Amazing.
Wonderful.
Excellent.
Amazing.
So she was right. She was right in deciding to refuse the surgery.
Actually, she was right, yes. Because
Actually, yes. And let me comment here that in the during the EADV, in the IDS session, we will present very analytically the results of a recent very important study on the use of imiquimod for lentigo maligna, and also the new guidelines of the IDS for lentigo maligna management, in which the role of imiquimod is definitely upgraded very much as compared to the current management guidelines. So it's going to be, I think, definitely a change in the practice in the near future.
Yeah.
no, but imagine the surgery that you need to do in order to exercise all these things.
Yeah, it's a
So you
lot.
need an anterior flap from here, and it's going to not look so good. And look at this result.
Amazing.
We can conclude that despite the patient's stubborn and cooperative attitude, this case had a happy ending. This last case does not have a happy ending like the previous one.
Oh.
Well, 90 euros. I don't think any comment is necessary. Dermoscopy, yeah, of course. It's okay. Breslow thickness.
Well,
8.9.
Yeah. I think more than 5. That's what all I can say. Nodular melanoma,
10 millimeter.
10 millimeter.
10 millimeter. No cellular reaction. Clinical history of flat pigment lesion that date back to the years before COVID. Patient exhibits a previous dermatological report that raised suspicion of senile lentigo, but suggests a clinical dermoscopic checkup after 6 to 12 months. We know that LM usually has a very slow progression and offers us the possibility of diagnosis during the follow-up. If anamnesis were reliable in our patient, we should conclude that there was a vertical growth, much more rapid than usual, with a huge worsening of the prognosis. This last case does not have a happy ending like the previous one. Don't skip follow-up. Remember to apply the inverse approach for early diagnosis of lentigo maligna. Thank you.
Very nice.
Wonderful. Grazie, Bruno.
Very nice, Bruno. Bravo, bravo. Wonderful.
A very nice reminder by Sebi. The last episode, so in 2 weeks, will be with cases sent by you. So please send us your best cases, your interesting cases, the ones that you want us to discuss, or the ones that you want us to challenge.
Great.
Question in the chat. What this?
Constance, we have more 2 case.
Oh, there is? Oh, sorry.
Yeah,
Sorry.
because they are of the previous episode, so I think it's good to do it
Okay,
today.
sure.
There is a question in the chat about the dosage of imiquimod for lentigo maligna, which is the regime for the 2 cycles. So when used as a monotherapy, we need long treatment time, approximately 12 weeks of treatment. Of course, it's important to assess also the presence or not of irritation. So if there is irritation, reaction, inflammation, then we need 11 to 12 weeks of continuous treatment with irritation. At least this is the scheme that they used in this radical study that is going to be presented in the EADV. In contrast, when you use it as an adjuvant therapy after surgery, then it's only 6 weeks. 6 weeks are enough.
Yeah.
Go, Kostas.
So, give me just 1 second. Okay. So, when appearances are deceiving a lot, Bruno Brunetti, Brown Little Brown, I love that. 75-year-old male, previous history of superficial melanoma, operated 2 years earlier, comes to our observation for this rapidly growing nodular formation in the left lower eyelid. No dermoscopic images to show, but I can report the lack of vascular pattern that could orient for BCRSC. Only a diffuse red-violet color was appreciated. It was decided to perform an incisional biopsy. Merkel, BC,
Merkel.
other hypotheses. It looks like a cyst to me, but yeah, Merkel is also an option. Histological shows a skin fragment with actinic damage, dermis in the site, granulocytic quota, intrafollicular attributable to dermatox folliculorum. Absence of images attributable to skin neoplasia.
Okay, so it's
Nice.
just rosacea.
Yeah. That's rosacea. Nice.
Wow.
Granulomatous rosacea.
Yeah.
Nodular, perifollicular, diffuse, and a combined perifollicular and nodular patterns. And after benrendazole, the case was completely resolved. A bath of humility is always necessary. Totally agreed. The more you think you know, the more ruinous the fall. What is it? Nicole Orendain from Guadalajara. 88 years old, hypothyroid, hypertensive, wheelchair-bound, 1 year history of asymptomatic lesion on anterior left thigh, mild renal impairment, rustic K, histology result.
Oh,
Granulomatous and suppurative inflammation without necrosis.
and this is Pyoderma gangrenosum.
Most likely, yeah. PG. Mycology results. Trix Senki. Resolution with traconazole. Okay, wonderful.
Very good. Excellent. Thank you. Thank you so much, guys, for the cases. Still questions in the chat. Do we have experience with imiquimod for melanoma in situ? No, not any other type than lentigo maligna. Guidelines, do they exist? Yes, and they will be presented. Well, not yet, but they will be out soon. And send it in the IDS session during the EADV in Paris in September. How long do you need to follow up? Well, long you need to follow up. Anyhow, even if you exercise this surgically, still you would follow up. So it does not really change. Okay, time for Kahoot, I think.
Yes.
Yes? You think so? Okay, if you think so, come on. Oh, I forgot to log in. Okay. Fast. It's gonna be fast. Don't worry. Don't worry.
Easy or hard?
Huh?
Easy or hard?
Well, not the easiest, not the hardest.
Middle.
Easy. Come on. Easy.
Middle.
Our audience who are impressively good, it's gonna be easy.
Bene. Rudy.
Poroma. Poromanista.
Romanista.
Allah sign. Thank you, my friend. Thank you.
I support Poromanista.
I support Lala sign.
You don't need to say who I support. Okay, let's go.
Let's go.
Episode 18. And we start with this case of a 50-year-old man with this lesion on his upper back. You see the halo of the resulting from the dermatoscopic examination. You see here dermoscopy. Okay. So this lesion was excised. Can you predict the histopathologic diagnosis? Congenital nevus, sclerosing nevus, melanoma, or solar lendigo? Visible?
Pararam. Well.
Sclerosing nevus. Sclerosing nevus, upper back, regression-like and fibrosis-like structures in the center, in line with sclerosing nevus. The age is a little bit higher than the usual, but it's in the game, it's accepted. When we have this combination, it's an accepted diagnosis, sclerosing nevus, which brings CNS in the first place, melanoma in the second, and poromanista.
Poromanista.
Second case, a nodule here on the forearm of a 40-year-old woman. That's dermoscopy. This lesion was excised. Can you guess the histopathologic diagnosis? Dermal nevus, atypical split tumor, melanoma, or BCC?
What looks like a dermal nevus, but doesn't look like a dermal nevus?
Is the dermal nevus. Dermal nevus. Yeah, good. 61 people found it. Yeah, it's nice. Very good. Taha D in the first place, CNS in the second, melanoma in the third, which brings us to case number 3. 28-year-old with this black thing. That's dermoscopy.
Network.
Annoying, eh?
Yes.
See, a lot.
Lesion was excised. Histopathologic diagnosis: blue nevus, lichenoid keratosis, melanoma, or BCC. And it is what it should be. It is a melanoma. It is a melanoma. Okay? Yeah. Tricky somehow, but feasible in the sense that it's not an homogeneous blue color. So
Yes.
okay, good. Which brings S in the first place, Thomas, which has the highest streak of 3 and is on fire in the second, and Taha D in the third, which brings us to case number 4. 35-year-old lady. That's the clinical. That's dermoscopy. And this lesion was excised. AKP diagnosis: Saturn nevus, lichenoid keratosis, melanoma, or BCC. I have to say that I'm playing bad a little bit with you with this case. I'm a little bit unfair with you, but let's see first the result. Saturn. I say that I'm a bit unfair because I didn't show you Taha D, by the way, is in the first place, CNS and R. I didn't show you the clinical.
Yeah.
Definitely help you to conclude that this is most probably a Saturn nevus. However, this particular one was excised because it was a little bit more ugly than usually, but it was a Saturn nevus. As it should be. And finally, 26-year-old man or boy, I would say, with a nodular lesion on the back. That's the close-up. We wish that it is an angioma, but as you can see, not really.
No.
And now the question is, of course, this was excised. And the question is, what was the diagnosis histopathologically? Dermal nevus, atypical Spitz, melanoma, or BCC?
We hope for a typical Spitz.
We hope for atypical Spitz, and atypical Spitz it was. Wow!
Yes.
The majority of the people will vote for atypical Spitz. So, and if I'm trying to decode why, first of all, it does have a spitzoid appearance in the sense that there are a lot of vessels, of course, and then probably the age is a reason why they opted to vote for the optimistic scenario as compared to the melanoma. Very good, very good. So, podium, third place goes to Dermademon.
Wow.
Bravo.
The place goes to Melan A.
Melan A.
Goes to Taha.
Taha.
Wow.
Bravo, Taha.
From the beginning, Taha D was there from the first question, I think. So, very strong performance tonight for Taha D. Congratulations.
He's from Turkey.
Wonderful.
Should be from Turkey, eh?
Yeah.
Is.
I know him.
I know Taha D. Taha, show up. He's here. Show up.
Sebi, bring him on.
Wonderful
Bravo,
guy.
Taha.
So, which is the conclusion of the episode? Dermoscopy fails sometimes?
Yeah, from time to time. As everything. Human beings fail.
Yeah.
Dermoscopy. Yeah.
Hey, Taha.
Hello.
Hello. Hi.
Hello, dear professors.
Bravo.
Hi. Very good job.
Tebrikler.
Bravo.
Teşekkürler hocam, çok sağ olun. Thank you so much.
Wonderful, wonderful. Which city you are in?
I'm in Sivas.
Sivas.
Sivas means Sebastian in also, yes.
Okay.
He is very hardworking.
Oh,
I know
thank you.
him, and congratulations.
Thank you, thank you, thank you dear professors. Çok teşekkür ederim hocam, çok sağ olun.
Did you do 5 out of 5 or not?
No, five out of 4.
4 out of 5. Which one?
Yes.
Which one did you miss?
Fourth question or third, I don't remember the question, but
Doesn't really
third, I
matter.
think.
But
Yes.
got the May, so he has flowers.
Yes. Yes.
Okay.
Wonderful, ragazzi, un bacione a tutti.
Teşekkür ederim hocam, çok sağ olun. Thank you so much dear professors.
Thank you, Taha. Baci,
Thank you.
baci.
Thank you, professor.
Ragazzi,
Bye
enjoy
bye.
the rest of the
Bye.
evening. Baci, baci.